Just waiting for the go ahead.
Should we get started, Dr. Mehmet?
Admit a few more people to accept. Mirza, welcome. How are you? I think only Corina. Good. Did not.
Yeah, Dr. Karina said she's going to be a little bit late. So we don't have to wait for her.
I think we can start today's webinar. It is together with the WFNS Education and Training Committee and what was the name of the the other committee?
Innovation and Technology.
Innovation and Technology Committee. And I will leave the scene to Dr. Theresa Williamson and Dr. Mohammed Abdelbar for these very interesting topics. Yes.
Perfect. Thank you so much. And
they will be the moderators.
Thank you so much, and welcome everybody to this webinar on augmented reality, robotics, and so on. This is a great pleasure to be here with all our friends and colleagues from all over the world. And we're going to get started with this webinar with she's supposed to be my mentee, but I think she's more my mentor because she teaches me more than I learn, or that I teach her, Dr. Theresa Williamson, who's an assistant professor at MGH, and will be talking to us about augmented reality as it relates to spine surgery.
Thanks so much for the introduction. I'm going to go ahead and play a pre-recording, but I'm here to answer any questions. I just didn't want too much background noise this morning. So I'm going to go ahead and play it. Just make sure you can hear it.
Thank you so much for coming to the conversation started about my experiences.
Sorry, but there is no audio.
Yeah, I'll talk about the basics of the setup and workflow in case you're wondering how to use it. Obviously, you can get more detailed training about how to use. Much for coming to the WFNS Education Symposium. We're going to talk about virtual reality. We're going to talk about robotics. We're going to talk about simulation today. Just really excited in general to get this conversation started about my experiences at MGH with augmented reality. I'm Theresa Williamson. I'm a neurosurgeon at Mass General Hospital. And today I'll be talking about simplifying surgery and using augmented reality to help simplify complex procedures. I'll talk through some cases, and show you how I think this technology can be incorporated amongst other technologies that I use in taking both a minimally invasive but also complex approach to the spine. I don't have anything relevant to disclose to this talk. For an outline for this talk, I'll talk about augmented reality and spine surgery. I'll talk about the basics of the setup and workflow in case you're wondering how to use it. Obviously, you can get more detailed training about how to use these types of technologies, and I would recommend doing that if you want to use them. But I think just going through what would it look like in your OR, and then maybe some of the reasons why I would use augmented reality. So to start with what augmented reality is in spine surgery. So augmented reality overall is an experience where designers enhance part of the user's physical world with computer generated input. So if you think about this from a video game, from an experience test driving a car in augmented reality, we're bringing some of the computer world into our physical world so that we can better understand in 3D form what the world is looking like. For a surgeon, it allows us to quote unquote see the patient's anatomy through the skin and tissue as though we have X-ray vision, and be able to really look and accurately navigate spine procedures. And the nice thing is it's right there in our real world, in our view, as we're working. And so I'll show some examples of that next. So there's no footprint in the surgical field. There's no, I have to put a chicken foot or however you call your navigation guide into the field. You're just looking, you're using those glasses. You can see this white headset here, and you're looking down at the field. You're seeing that superimposed computer generated image as you're using your driver or whatever instrument you're using. This is how the image can look when you're up on the screen. You can have, pretty substantial detail, and you can also change your viewpoint. And so this is a sagittal view, axial view, and then you can also look in 3 dimensions. I do like that 3-dimensional view. It gives you an opportunity, I'll show you, to use it beyond just placing pedicle screws. I think there's some really other interesting ways to use this technology when you get to rotate that 3D model in real time in your glasses. So it's flexible. You can use it for multiple different instruments. Here's an example of using it to place a K-wire through a Jamshidi K-wire tap and screw technique. And so looking at that navigation in real time and using it on multiple different instruments, because the adapters can typically adapt to multiple different instruments. So going into the workflow, the first step is to place a patient reference marker, and then you're going to do an intraoperative 3D CT scan. Once you do that, you'll have the headsets. I typically would scrub out to put on the headset, only because it's heavy, I think, to wear for the entire case. So if there's a part where I want to use augmented reality, I would typically have the team scrub out. One of the things about this is the case we're doing together. And you can see that 3 of us are wearing headsets, but actually only 2 headsets are live at a time, just based on the limitations of the current technology. That is one limitation, especially if you work in a teaching hospital like I do, because it can make it a little bit more difficult for the trainee to also be seeing, or multiple trainees to be seeing. And so there is a screen also in the room to show your trainees what's going on. The great thing about that is once you have this augmented reality, your eyes are always on the patient. So you're looking down, your reference array is in the field. You don't have to have a camera or another eye being able to see you, and you can see everything in real time. This is the setup as it looks in our OR. So here's the O-arm spin coming in. Here's the augmented reality screen to capture and get that those reference images. And then we have the rest of our surgical setup. So how do we actually use that in reality? And so I have found it really helpful to augment or to add to some of my cases that I already am either worried about challenging anatomy or want to be more efficient in my approach for any particular reason. And so I'll show you some of those cases. So this was an interesting case of a 49-year-old with sickle cell disease who had congenital autofusion all the way from the occipital cervical junction, and then a large upper cervical autofusion, and then at the mobile segment at C7T1 between the cervical and the thoracic spine, one of the remaining mobile segments in his spine, he had developed severe disc degeneration as well as ligamentous overgrowth, resulting in cord compression, cord signal abnormality, and a really pretty acute progressive cervical myelopathy. And so for this case, because of his sickle cell, he had a long-standing history of sickle cell. He'd actually done very, very well for almost 50 years, but he had developed a lot of collateral vessels, and so it was a really tricky case to navigate where we were going to put screws. This is an example at T1. You can see these large feeding vessels, way more vascular than typical at the pedicle, and potentially with collaterals into important cardiopulmonary structures. And so we wanted to make sure that we were really accurate in where we were navigating these screws. So we got good fixation, good ability to put the screws in, and then also ability to do the decompression. I should note that actually, because of his immobility of his cervical spine, they were unable to approach anteriorly. He had a trach for a year from a prior surgery. And so our ENT folks were unable to give us anterior access safely with his airway. And so that's why we had to do a posterior decompression infusion. And so this really helped us to work amongst those limitations, can't go from the front, need to go from the back, multiple vascular collaterals. And so looking in real time and being able to see that CTA, as I showed on that prior slide, while we're placing the pedicle screw, really did make that case go more smoothly. He's done really great. He's almost 2 years out now, and has not had a problem, regained his ability to walk and be independent, and is really happy. So here's another example of where challenging anatomy or situation can be aided by augmented reality. So in this particular case, this is a 75-year-old with osteoporosis, progressive height loss, and retropulsion. She had a kyphoplasty at 2 levels prior. The second level had a near vertebral plana and actually retropulsion of the cement into the canal. And so in this particular case, we wanted to be able to complete a VCR to help with her alignment a bit, but also to get that retropulsed cement out of the canal. And so this was a case where we wanted to be able to both see for placing our screws so we could get a good pedicle screw around the cement above and get an extra point of fixation in a patient who is pretty medically sick. And we also didn't want to make multiple pass or tracks in someone without very strong bone, and then also use it to navigate the drill, which is an off-label use still at this point, but to help us to drill off that cement fragment, obviously in a very sensitive area. And so this is an example of using the augmented reality to help us to place that screw just up to the cement and being able to see that in real time. And then I'll show you later on, as I show a different case, how we did it for the bony work and drilling off the cement. So she also ended up doing quite well. When we have difficult angles, this technology can also be helpful. It's kind of interesting. This is not a case that I would do or be in a situation that I would be in all the time, but this is an example of when, taking a different technology out of your toolbox might be helpful. And so this was a 50-year-old woman who had just an absolutely miserable 6 months of refractory pain, inability to walk, multiple trips to the hospital, multiple rehab courses, tons of physical therapy, an attempt at weight loss, medical management, and bracing, and just could not get ambulatory due to this bony chance fracture at L2. And just inability to stand up or bear weight. And so finally, she was transferred to our hospital for an attempt at stabilization. I was really concerned given her size, actually. We were unable to get good x-ray pictures so that we could, see well. And then it was going to be really difficult to navigate, to have a patient array visible, to get her through the O-arm, and then also to have the patient eye see the reference array at the same time that it was seeing our instrument, just based on the depth of the working field. And so I do think that augmented reality made this case substantially safer and easier to do. This is a different case example, but what we were able to do is open to the fascia, put on a spinous process clamp, and then we're only looking down at our clamp. We don't need a camera to see over her subcutaneous tissue in order to do that. And so we were able to place our screws safely that way, and she ended up doing quite well. You can see here where you can actually see through your glasses and you're looking straight down at that patient array. And that was really, really helpful in this case. She's done really, really well. This was an older slide, but she's now out about 2 years. And so this is another example when you want to be efficient in a big case. I think it's also helpful. This is an off-label use, again, of using augmented reality to navigate the drill. And so this was a patient with a upper lobe Pancoast tumor that had invaded the spine around C7, T1, and T2, T3. And so we ended up doing this is a case that I did with one of my partners at the time, John Shin, where we exposed a large portion of the cervicothoracic spinal cord to make sure we had a good wide decompression. You can see the tumor here. You can see the T1 nerve root with the yellow band, and the T2 and T3 nerve roots that had to be sacrificed due to their involvement with the tumor. And so we were able to actually take the take the tumor and resect it away from the cord, but then we also needed to make a vertebral body wedge cut so that we would get a gross total resection, which is really important for prognosis in patients like this. And so we actually then scrubbed out, put our headsets on, and navigated the drill in order to make an exact wedge cut where we knew tumor was infiltrating, so we could, at least based on imaging, try to get that gross total resection cut. And then our cardiothoracic surgeons were going to come the following day in order to be able to actually resect the rest of that tumor anteriorly. And so here's an example of drilling down there. Yeah. And this is the CT scan example of where that wedge is, and you can see the exactness. And so it was very efficient to be able to have that marker on the drill and just be able to work right in that plane without having to look up multiple times, check where you are on imaging. And so this is kind of where we get excited about, okay, what can we do in the future with this type of technology? Because then we were able to combine with a robotic approach. This is one of my cardiothoracic partners, Hugh Auchincloss, who then was able to resect the rest of the tumor off of the vessels from the front and complete the gross total resection, removing that tumor anteriorly in a robotic fashion. And so this is the tumor when it came out on block. This is the post-operative fusion. Patient had a long hospital stay, but ultimately discharged to rehab, is now over a year out, just doing fantastic, no recurrence of disease. Going back to how we can use this for confirmation. So this was another bony cut. This was that prior case that I had showed you where that vertebra plana existed, and we wanted to do a vertebral column osteotomy there. And so this is again using that drill to do that and being able to get improved kyphosis on that correction, as well as drill out that cement fragment, which was really the goal of that case, to prevent her myelopathy. And so going back, that's what we reviewed, is how we could look at different case examples of when to integrate, when to pull augmented reality out of your toolbox and use it. And I think there are some really great and interesting times to do that. So, thinking of this in general, I'm excited to imagine the possibilities of what we can do with augmented reality. I think there's a lot we can do. I think it's not the only technology we can use, which is why I'm excited to have the future speakers, because I think that they'll be able to help us understand how we can use other technologies as well. And ultimately, you can choose what's in your toolbox for what's best with your case. So I'll take any questions. I'm happy to be here, and again, excited for our others.
Thank you so much, Dr. Theresa. That was amazing, as always. Because of time restraints and so on, maybe we'll have time for 1 or 2 questions.
I have a question, if possible. In your opinion, is more valuable to use the navigation or the augmented reality? Because it seems to have an integration between navigation and augmented reality in your cases. And if yes, what is the plus of the augmented reality with respect to standard navigation?
Yeah, so I would say for my everyday case, I'm still using navigation. I'm either using the robot or I'm using navigation guidance. And so I think the benefit to this case is in some of those examples where it's just a little bit, you have that, okay, I really want to have my vision on the field the whole time. I don't want to be looking up. I don't want to, I want to do it for my osteotomy cut, or I have difficult anatomy and I want to be able to just be sort of focused the whole time. Otherwise, I think the technology, just to be perfectly frank, in my opinion, like the headset's a little bit heavy. You have to scrub out. Only 2 people can wear the headset. So there are some technical limitations still at this point. I do think once it's fully integrated into like a, glasses type of a thing, then it will be so easy that you could wear it the whole case with your loops. And I know that's coming. And at that point, I think it'll probably challenge me to probably shift my practice a little bit to use augmented reality all the time. At this point, because of some of those technical limitations, it's still more of an add-on special case in my practice, at least.
Thank you. Probably is more valuable in a percutaneous procedure because you're able to understand really the three-dimensionality of the anatomy with respect an open surgery where navigation probably is enough. But it's just an opinion because I use navigation, but not augmented reality. So I'm very curious about this.
Exactly. I think that, that one thing where you look up at the screen and your hand kind of tilts down a little bit and you're constantly sort of readjusting for perc cases, I think that looking straight down does take away a little bit of that. So there's some benefits. You just have to balance them with having another technology and workflow in your OR.
Thank you very much, Theresa.
And Dr. Theresa, right now, that technology is only using CT. Is that correct? Is there work to combine MRI in there as well, or not yet?
Yeah, so you can actually, if you upload, you can layer other images and merge. So I did for that one case layer the CTA with the CT. Still not quite there with MRI, but I do think that's coming. And so I did like it for, even though it's an off-label use, navigating with the drill or things like that when you're looking around structures, when you're doing a tumor resection. I think that's coming for sure.
Awesome work as always. We'll move on to our next speaker, Dr. Mirza.